Okay, we are done with gram-positive organisms. It is time to move on to the gram-negatives. Here we start again with another algorithm that will be really helpful to you in organizing the classification of all the different gram-negative species. The classification scheme is a bit easier for gram-negatives, which, by the way, are what color on gram stain? Pink or red, unlike gram-positives, which we said are dark purple. There are four main shapes that gram-negative organisms can take: cocci, rods, coxoid, or coxobacillary, which are rods that are very short and comma-shaped organisms. Of the cocci organisms, you thankfully only need to know two species of bacteria which are within the same genus, Neisseria meningitidis and Neisseria gonorrhea, which we'll talk about in a few moments. Within the coxoid and coxobacillary focus, we're going to talk about Haemophilus influenza and Bordetella pertussis. Within the rods, focus mostly on these organisms: Klebsiella, E. coli, Shigella, Pseudomonas. We will talk about the lab tests that help distinguish these bugs as we go through them individually. And finally, there are only two comma-shaped organisms that grow on a stool culture from a person with diarrhea that you must know: Vibrio cholera and Campylobacter jejuni. Remember the buzzword comma-shaped, as it is often used on the boards and immediately tells you that you're dealing with either cholera or Campylobacter. McConkey's agar will be helpful to you in distinguishing the different gram-negative rods. This medium tells you whether your organism is a lactose fermenter or not. Those that use lactose as a nutrient source will contain beta-galactosidase to break down lactose into glucose plus galactose. So lactose goes to glucose plus galactose. So here's our plate of McConkey agar. I would focus on knowing that E. coli and Klebsiella are lactose fermenters, therefore appearing as pink colonies. Lactose non-fermenters, such as Pseudomonas and Salmonella, will appear white on McConkey's agar. There's another type of agar you can use to further help identify the bacterium: EMB, or eosin methylene blue agar, seen here. Lactose fermenters will be purple-black, but E. coli will have a special appearance. On the boards, look out for the key words: metallic green sheen. This describes E. coli when grown on EMB. When it comes to gram-negative bacteria, there are only two important cocci species you need to know: Neisseria gonorrhea and Neisseria meningitidis. Both ferment glucose and appear as diplococci, which are pairs of cocci. However, Neisseria meningitidis can be distinguished from gonorrhea by two features. First off, as you can see from the cartoon diagram, Neisseria meningitidis has a polysaccharide capsule, which Neisseria gonorrhea lacks. This capsule inhibits phagocytosis and increases virulence. Secondly, while both are glucose fermenters, Neisseria meningitidis also ferments maltose. I've illustrated a little visual mnemonic for you here to help you remember this. Note the G and the M of glucose and maltose in meningitidis, and only the G for glucose in gonorrhea. Let's talk about Neisseria gonorrhea first. This organism is responsible for the sexually transmitted disease, gonorrhea. An important method for isolating Neisseria bacteria from clinical samples is to grow the specimen on Thayer-Martin medium. Thayer-Martin medium contains VPN agar, which consists of vancomycin, polymyxin, and nystatin. Here's our VPN plate here. So we plate some bacteria. Vancomycin is going to inhibit the growth of gram-positive organisms. Polymyxin is going to inhibit the growth of any other gram-negative species, and nystatin is going to be there to inhibit fungal growth so that only Neisseria will be able to grow. Gonorrhea is transmitted via unprotected sexual intercourse. Uncomplicated gonorrheal infections will result in purulent urethritis for males and symptoms of dysuria and penile discharge, so urethritis. Infected women can experience acute cervicitis with abdominal pain, vaginal discharge, dysuria, or sometimes no symptoms at all. But if you do see symptoms, you're commonly going to see cervicitis. Treatment involves a third-generation cephalosporin antibiotic, usually intramuscular ceftriaxone injection. However, because gonorrhea often co-infects with chlamydia, which we'll talk about later, you usually want to treat for chlamydia also with an antibiotic such as azithromycin or doxycycline. So a very commonly used combination is doxy plus ceftriaxone. On the boards, you'll often be asked to diagnose gonorrhea and then be asked how to treat it. Always treat for both gonorrhea and chlamydia. So, what happens if you have an untreated gonococcal infection in a female? No big deal, right? Wrong! Actually, there can be devastating consequences. A serious complication of untreated gonorrheal disease in females is an ascending infection, whereby gonorrhea spreads to the uterus, fallopian tubes, and ovaries. This is known as pelvic inflammatory disease. This is a big deal. Symptoms in PID consist of abdominal pain, cervical motion tenderness, dysuria, fever, nausea, vomiting, and chills. PID is dangerous because it can lead to tubo-ovarian abscess and scarring, which increases the probability for infertility or even ectopic pregnancy. The key finding that you'll see on your exam, and they will always tell you this, is cervical motion tenderness, not country music television, cervical motion tenderness. Cervical motion tenderness is pain that is elicited by palpation and pressure placed upon the cervix. If you see this buzz phrase, you know your diagnosis. A rare complication of PID is called Fitzhugh-Curtis syndrome, whereby inflammation of the uterus and oviducts can cause subsequent inflammation of the connective tissue surrounding the liver. Symptoms may include acute onset of right upper quadrant pain aggravated by breathing or coughing, and then there is also referred pain to the right shoulder following an episode of PID. Violin string adhesions that you can see around the liver, here they are right there, those violin strings. Babies born to mothers with gonococcal infections may develop ophthalmia neonatorum as a result of passage through an infected vaginal canal. This will present as an acute purulent conjunctivitis several days after birth. This is the basis for all newborns receiving prophylactic intraocular erythromycin. As you can see here, this is a bilateral purulent ophthalmitis, and it generally presents within a few days of birth. Gonorrhea is also the #1 cause of septic arthritis seen in sexually active adolescents. However, what is the most common infectious cause of bacterial septic arthritis? It is our friend Staph aureus. Hang on just a sec. Let's talk about septic arthritis real quick. Do you remember the signs and symptoms of septic arthritis? Well, it usually presents with an acutely painful swollen joint. Usually there are some systemic signs of infections like fever, chills. You check a CBC, you'll find an elevated white count. Okay, so we suspect septic arthritis. What must we do next? Needle aspiration. We need a diagnosis. So let's get some fluid out of the joint and send it for gram stain, maybe some cell count and culture. What do we expect to find if it is bacterial septic arthritis? Hope you're saying WBCs in bacteria. In bacterial cases, WBC count is typically greater than 50,000. That's really, really high. 50K. Okay, hold the phone. So I'm telling you there is bacterial gonococcal septic arthritis and non-gonococcal arthritis. So how do you tell the two apart? Well, non-gonococcal arthritis, which as we said is commonly caused by Staph aureus, is commonly monoarticular, meaning that it usually affects just one joint. So our guy would have a really swollen knee joint and he is not going to be happy. Whereas gonococcal arthritis is typically polyarticular. So our guy might have a swollen elbow joint, he might have a swollen knee joint over here, he might have a swollen ankle over there. He's also not going to be very happy. He also might have some skin findings. There is no vaccine because the polyproteins of Neisseria gonorrhea undergo such rapid antigenic variation that it is virtually impossible to establish long-lasting immunity against them. Okay, that was a whirlwind tour of gonorrhea. Now let's talk about Neisseria meningitidis. This organism is responsible for causing bacterial meningitis in adolescents and populations within close quarters, such as military recruits or college dorm residents. Meningitis is inflammation of the meninges, the membranes which cover and protect the brain and spinal cords. Symptoms include abrupt onset of headache, fever, chills. You'll classically see the term neck stiffness, as well as nausea, vomiting, and photophobia. So what is the diagnostic test of choice if you suspect meningitis? Well, you're going to want to obtain a lumbar puncture, or an LP. In this test, you're going to pass a needle into the subarachnoid space, which means below the arachnoid, subarachnoid space, and withdraw CSF. So that tells you that CSF is going to be in the space between the arachnoid and the pia. Just a little bit of neuroanatomy coming right at you. Once you're in the subarachnoid space, you're going to withdraw CSF. You'll talk more about the various cell markers of the causes of meningitis later, but while we're here, let's talk about what you'd see on an LP from meningococcal meningitis. So there are a few things you would look for on LP, right? WBCs, glucose, and protein. In bacterial causes of meningococcal meningitis, what do you expect to see with WBCs? Really, really elevated, right? Yes. And how about glucose? Well, what do bacteria and little kids have in common? They both love sugar. Bacteria are going to be in there going absolutely nuts on your glucose. That's how they get their energy. So glucose is going to be really, really low. How about protein? Protein is actually going to be elevated. Excellent. This always shows up on the boards in some form or another, so be prepared to analyze CSF. Neisseria meningitidis can also lead to disseminated meningococcemia, a life-threatening meningococcal sepsis during which small vessel thrombosis and DIC, or disseminated intravascular coagulation, result in severe multi-organ disease. Petechial or purpuric rashes are often seen on the trunk and lower extremities, as you can see here. This is what petechiae look like. You can also see some areas of purpura as well. Petechiae are the smaller punctate lesions, whereas purpura are the larger lesions. So let's talk about our patient who you suspect has a little case of meningitis. No big deal, right? Take your time getting to the doctor's office, maybe catch a cab on the way. No. What is the feared complication with meningococcal meningitis? So our patient shows up to the ED. He's got fever, hypotension, and some of these petechiae scattered all over his body. What is your diagnosis now? Waterhouse-Friderichsen syndrome. Oh boy, Waterhouse-Friderichsen syndrome is bad news. This is a board question, guys. This is a board question. And who's going to nail this one? You are. Fulminant meningococcemia can result in septic shock, as well as bilateral hemorrhagic adrenal glands, which is a result of infarction of the adrenals caused by the DIC. Destruction of adrenal glands leads to hypotension, hypocortisolism, hyponatremia, and hyperkalemia. One more time. Low cortisol causes low sodium, high potassium. If you see these metabolic derangements in your electrolytes, think about adrenal insufficiency. You're going to learn more about these when you're presented with adrenal insufficiency in the endocrinology section. Meningitis can be treated with a third-generation cephalosporin, such as ceftriaxone. Rifampin, ciprofloxacin, and ceftriaxone should be given as prophylaxis to close contacts of an infected individual. There is also a meningococcal vaccine, which is recommended for adolescents aged 11 to 12. It covers 4 of the 5 most common serogroups. This vaccine has capsular polysaccharide that stimulates the development of anti-capsular antibodies. The conjugate vaccine is currently recommended to everyone going into college or the military.